Hi, I'm Dr. Carrie Loonan. I'm a GP in Edinburgh and I'm Chair of Scottish Council at the Royal College of GPs. And I'd like to welcome you all to the fourth in a series of live panel events that the RCGP is hosting for our members. This week, we're talking health inequalities and COVID-19. And if you haven't watched before, these sessions are about being able to speak directly to our members about what the college is doing and how we're working for you and your patients during this difficult time. You can put your questions to us using the hashtag RCGP Together Live on social media or write them in our online member forum. So we're talking about health inequalities this week, which is an area that we've prioritised and undertaken a lot of campaigning work around during my last 3 years as chair in Scotland. And I believe that GPs have a unique opportunity and a crucial role to play in tackling health inequalities. I practice in an area of significant socioeconomic deprivation in Edinburgh, and I'm part of the Deep End group of practices in Scotland, which was established more than 10 years ago and represents the practices serving the 100 most deprived patient populations in Scotland. COVID-19 has shone a spotlight on the health inequalities that already existed in society, with death rates from COVID-19 twice as high in the most deprived parts of the country. So I am delighted to host this week's panel on this topic. So who do we have on our panel for this evening? We've got a great lineup, and I'm going to call on each panelist now to say who they are and where they work, and then we'll start the conversation. So I'd like to start with Rachel.
Hello, I'm Rachel Steen and I'm an ST3 GP in Sheffield. Alongside my clinical work, I run the Trailblazer GP scheme. This is a post-CCT fellowship programme for supporting new GPs working in areas of deprivation across Yorkshire and Humber. I'm also part of a group of GPs who have created a website called Fair Health. This is an online educational resource, including a podcast, Finding Fair Health, looking at the challenges and solutions around tackling health inequity. I also sit on the Health Inequality Standing Group at the college. I'm really looking forward to the discussion this evening.
Thanks, Rachel. And next we have Amanda.
Thank you. I'm the college president. I'm a GP in Norwich and an academic at the Norwich Medical School. And I'm really looking forward to the panel. Thanks.
Thank you. And next we have Becks.
Hi everyone, thank you very much for having me on. My name's Becks Fisher. I'm a GP in Oxford. If anyone knows Oxford, you probably imagine Dreaming Spires. I work in part of it called Blackbird Leys, which is equally amazing but very socioeconomically deprived. I do that for 4 sessions a week. For the remaining 3 days of my week, I'm a senior policy fellow at the Health Foundation.
Thanks, Becks. And next we've got James. Oh, James, we can't hear you.
Hi everyone, I'm James Madison. I'm a GP with Hopes Dell Healthcare. I also work in Deep End practice in Deep End Greater Manchester and I practice in Oldham. In my other work, I do some academic work, teaching and training with the Shared Health Foundation around health inequalities. And most recently, I've taken over the chair of the Health Inequalities Standing Group at the college.
Thanks, James. And next we've got Andrea.
Hello, I'm Andrea Williamson. I'm a GP in Homelessness, Health and Addictions in Glasgow and also work at Glasgow Medical School. I'm Deputy Chair of the Health Inequality Standing Group and a founding member of GPs at the Deep End, Scotland.
Thanks, Andrea. And we've got Zana.
Hi, I'm Donna Khan. I'm a GP specialising in homeless and inclusion health. I work as clinical lead for the Pathway Homelessness team, which is an inpatient specialist homeless healthcare team, the South London and Maudsley Mental Health Trust, and as a sessional GP for the Great Chapel Street homeless practice in Westminster. I'm also a GP fellow at UCL, researching educational needs and interprofessional training for frontline staff, and was recruited by James to join the Health Inequality Standing Group this year as well.
Fantastic. Thank you, Zana. And thank you all so much for joining us this evening. I'm really looking forward to our conversation. So the first question is coming from Amanda. So I'd like to just hand over to Amanda for the first question going to the panel for this evening. Thank you.
Thank you very much. I'd like to thank everybody who's listening out there, talking about this really crucial subject. And I'd like to thank the whole panel for their passion and their commitment to this, for their work leading the college with their ideas and work on the standing group. The thing that strikes me as president is that our members are actually in very diverse populations and very diverse practices. They're not necessarily GPs with a special interest in health inequalities. And so my question is, apart from giving every patient good clinical care, what are the things what would the panel say is essential and feasible for any practice to do that's going to make a real difference to health inequalities?
Thanks,
That's
Martha.
the easy one.
Thank you. I think it's a great question, because the issue of health inequalities, I think, can often feel a bit overwhelming to us as an individual GPs, and we might feel there's nothing that we can do to change things, or is there? So I'm wondering, I'd love to put this question to the panel first to see what we feel is essential and feasible for practices to do. So I'm going to look for hands. I can see Andrea's hand going up first. So Andrea.
So when we're thinking about what GPs can do to help tackle or mitigate health inequalities, I think one of the really important things, which, as you say, Kerry, every general practice in the country is different, and that's what makes working as a GP such a fascinating, amazing job. But the thing I think that would be really useful for people to start thinking about is who's missing. Who do we not see in our practices? And I think one of the things that this opportunity of the COVID time has given us is that for many of us, there has been a bit of a pause. We're a wee bit off the sort of rabbit run of busy, overwhelmed by demand. And maybe this is an opportunity for each of us as GPs to take a step back and say, right, okay, who am I? Who's less visible in my practice? Who has unmet health needs that we are not seeing? And how can we tweak the way we offer appointments, the way we set up our services? And I'm mentioning this already in the first 5 minutes of the pattern of the session. Where does the new digital, the new digital age that we've been catapulted into, where does that play a role in that?
Thank you, because I'm sure that will come up throughout this evening. It's such a big feature of how we're working now. James.
Yeah, I absolutely agree with Andrea on that. And I think in answer to your question, Amanda, I think what we can do is what we do best in general practice. And I think that is provide high quality, but high quality holistic care. The thing is, we need to do it where it's needed most. And that means what Andrea is talking about. It's reaching out to the people we don't see, or the people we don't see often, but who have the greatest needs. So if we really want to make a difference to our practice populations and really kind of confront the inequalities we're seeing, we do have to reach out to those kind of folk. And that is harder to achieve, but it is achievable. And like Andrea said, we've been seeing a lot of that actually happening during COVID. And we've been hearing a lot of reports of practices being really proactive in this regard and identifying their patients who are vulnerable to the disease, but not just medically vulnerable for other reasons as well. So people who are at risk because of their mental health, because of poverty, because of exclusion, because of domestic abuse, for all sorts of different reasons. And practices are reaching out and making contact with these folks. And I think if we really want to make a difference, we need to think about what determines people's health rather than just their health consequences. And if we maintain our contact with these populations within our practice populations, and if we start really addressing those kind of matters, the things that make the difference between people being healthy and unhealthy, that's a really good way to make a difference.
Absolutely, thanks, James. And I've heard you talk about, and we've been trying this in our own practice too, just identifying who's our top 20 people that we worry about in normal times that we're just not hearing from, and then doing some outreach phone calls to them based on the health inequalities guidance on our website, which I shall mention frequently this evening, and just going through those questions. So, how are you? We've not heard from you for a while. How are things at home? Do you feel safe? Have you got enough money? Do you feel safe at home? Do you need any help with food? How's your mental health? And our care coordinators in our practice have been doing that, but social prescribers, link workers, but lots of people can have a role in this. And what we've found in our practice is that 80% of the calls that have been made have ended up in a referral to a food bank or citizens advice or a welfare advisor or internally to a clinician. And for a 5-minute phone call, massively appreciated by patients who, many of whom didn't actually realise we were open, because the public messaging just doesn't, we can't assume that it reaches everyone that we want it to reach.
Yeah, that's so important at the moment, but it's important all the time, really, isn't it? And I reckon if we'd been making those phone calls a few months back, we'd be getting huge proportions of those people we've been able to help then as well. And the same will be true going forward, I'm sure.
Yeah, absolutely. I saw Beck's hand up and then Rachel, yeah?
Yeah, just briefly, I completely agree with everything everyone's already said, and I know, loads of people will be innovating amazingly. I think that's one of the things that COVID has brought us. Amanda, I agree. We've had this time. I certainly feel excited by the amount of creative thinking that is happening in the practice I work in at the moment, and we've been working much more closely with our social prescribing link workers, our nurses who haven't been doing as much face-to-face contact, have been doing some fantastic calls with patients, as you say, Kerry, just asking people how they're doing. That's really important. But I just wanted to step back from kind of the individual GP, the individual practice for a moment, because I guess a narrative that worries me slightly with my bigger picture hat on is that if we continue to say, look, the responsibility for sorting out health inequity in your community lies with general practice solely and with individual GPs and individual GP practices, what we're overlooking is that actually they're structurally underfunded relative to need and understaffed relative to need. And so stepping back, I would say, well, what we can do as individuals and individual practices is hugely important with our own communities. But I guess, can we also work with the wider system, with our commissioners, with our PCNs, to say, actually, you need to give us some resource to be able to do this really well, because otherwise you're just increasing to workload and that spirals problems, it doesn't solve them.
Thanks, Bex. I mean, I was going to come to you on the bigger picture stuff, actually, just in terms of what kind of changes do we need to be seeing in national policy, and what should the college be calling for to address, structural deprivation and inequality? Do we have the evidence to show it's affecting health outcomes? I think we do. And we've had a question from Connie in our wellbeing group about whether, for example, socioeconomic factors should be included in the Equality Act. Is this something that the college should be lobbying for? It's an interesting question.
Yeah, I don't want to totally hijack Amanda's first question by going on to the kind of bigger picture at the moment, but I guess you would expect me to say, look, there is really clear evidence for the impact of socioeconomic deprivation on health outcomes. We know Michael Marmot's 10 years on report showed that the healthy life expectancy gap is widening. It's 12 years now, not 7 years. I mean, it's shocking. Where I work, there's a 7-year gap in life expectancy if you travel 3 miles across the city. Life expectancy is a crude measure, but by whatever one we look at, multimorbidity, the age at which you accumulate multimorbidity, we see that more deprived populations have worse health outcomes. I think the bigger picture for me, and I guess I could be accused of being fairly repetitive on this, but is I would love to see college really calling for changing in funding and changing in supply, in staffing. And to me, whilst we continue to be funded predominantly by Carr-Hill, by a formula which underweights significantly for deprivation, we're going to have a real challenge on our hands kind of trying to solve it. And I think I alluded to some of the problems with that earlier, but we're kind of piling up a vicious cycle of workload and pressure on the areas of general practice that have the most work to do in this regard and are also the most vulnerable.
Absolutely. And certainly it's been one of our campaign asks in Scotland. So more funding overall for general practice, which is always going to be something we campaign for. And then how do we target resource according to need? How do we make sure that the NHS is at its best where it's needed the very most? Rachel, I was going to ask if you could come in. So just going back to Amanda's question about what can we do within practices as individual GPs. You've done some really interesting work in some of the things you mentioned in the opening introductions.
Yeah, so thanks, Kerry, and just bring it back to more patient and practice level, but I completely agree with what Becks has just said. So as Amanda says, I think doing the clinical work is really, really important, but seeing that in the broader perspective of the community in which the practice sits. And I suppose I come from a sort of trainee perspective, and I think it's really important to think about who the vulnerable groups are within your own specific practice population. And that's something that I've had an opportunity to do in the practices that I've been working in, and that's been fantastic. But also thinking about how we can bring in the social determinants of health and so advocate for these groups and advocate for these issues. I know James, for example, they've got fantastic link workers, so focused care workers, really doing great work to advocate for their patients at Hope Citadel in Oldham. And I suppose the other thing that I think, so as trainees, we're focusing on exams and trying to do the clinical work stuff really well, but I think it's really important not to forget the impact of kindness and continuity of care too. I think there's something to be said from a trainee point of view about sort of practice level stuff, because I think it's something that only recently trainees are having an opportunity to think about. So where, as I said before, where the practices sit within the practice population. So in Yorkshire and Humber, we're doing some social accountability placements for ST1, so they're having a chance to go out into the community and spend time within the community and get to know their community. It's also sort of thinking about how we can work in collaboration with local services, and by that I mean that as a two-way thing. So I think quite often we say we're working with services, but actually services are doing a lot for us. But actually, how are we supporting the services within our community? So we're actually sitting within our community, and I know practices like Bevan Healthcare in Bradford are doing this brilliantly. So really sitting as part of the community. I'm currently leading a programme called the Trailblazer Scheme, which is a post-CCT fellowship scheme, and it's been amazing to see how much peer support has been incredible for GPs early in their career, working in areas of deprivation. And I think that's something else that ensuring that GPs throughout their career have opportunities to form networks and have support from each other going forward is really important.
Thanks, Rachel. No, it feels really, really important to embed this in training earlier and kind of spark the awareness that actually we do have really crucial roles to play, because I think it came to me later on, and I think if I'd had the opportunities that you described, that would have been fantastic. We've got a question from the forum, but I'm going to come to that just after I've asked Zana for her thoughts on this as well, and then we'll move to the question that's come in, which is a good one.
Yeah, so just to sort of think about this from a slightly different perspective, I've been very involved in working with the homeless hotels that have been set up across London, and seeing the response from primary care has just been phenomenal. All these GPs stepping forward to become inclusion health GPs, inclusion health practices, who have no history of working with people experiencing homelessness or other forms of extreme social exclusion, coming into hotels, doing clinics, registering patients, supporting their prescribing, supporting their addictions has just been amazing. And what it made me think about is actually we are all inclusion health GPs, and what the research internationally shows is that primary care is the most innovative in the care of socially excluded groups, because our training, our practice lends us to that. If you look at where is the care for prisoners? GPs and practice nurses. Where is the care for refugees? GPs and practice nurses. Where is the care for people experiencing homelessness? GPs and practice nurses. So we are all really equipped to do this. And having seen this incredible response through COVID-19 of this stepping up of a real change, shift change in approaches to care, and lots of simple things that have made a real difference. That open registration, not limiting to addresses, it doesn't matter, not limiting to immigration status, that does not matter, and recognizing that actually those are barriers to people being able to access healthcare. as I've said, GPs reaching out to the hotels, coming to do clinics in places that they haven't done clinics before. And that is a principle that could be taken on really by any locality, any CCG. There are now lots of examples of very innovative strategies, whether it's creating a directly enhanced service for a whole CCG, or whether it's doing training in the safer surgeries or the fair health training that's also been created, reaching out to day centres, reaching out to refuges. I think often people who are experiencing social exclusion are thought of as hard to reach, but how easy are we to access? So turning it on its head and thinking about actually where, like Kerry said at the start, where are the people that I need to reach out to? Who can help me do that? Are there outreach workers? Are there social prescribers that can help me do that? Has been really transformative and become now part of the narrative and part of the norm, certainly in the areas that I'm working in, and spreading and sharing that experience, I think is key to show that it doesn't have to be big, it can be small and effective.
Thank you, Zana. Absolutely. And the question that's come in, I guess, is kind of following on a little bit from this around our role as a college in campaigning or advocating for maybe our more vulnerable patients. And it's a question from Mohammed from the forum. If footballers are campaigning on school dinners for children, has the college taken its eye off the ball? Love a pun. What wider campaigning can the college be doing for population health to address health inequalities? And I guess it's worth remembering as well that the college is a member organisation, that we are our membership. So I think it's useful to think, what can the college do as an organisation? What can we do as GPs, as individual practices? Do we need to be thinking about having inclusion health leads within our practice in the same way that we have a diabetes lead or a COPD lead or whatever it is we have? Is that something that, you know, this may offer us a new kind of lens to look at things through? But I'd be really interested to hear from the panel what your thoughts are. So if you can maybe just physically raise your hand, because I'm not sure whether the old hands are still the new hands or what. So we'll go with Andrea first, please.
Yeah, so I think this is I was really struck by the fact that it took a footballer to penetrate the Teflon coated armour that seems to be current Westminster thinking. After many decades of campaigning on these issues by many groups and many of the groups that the RCGP supports. And I suppose what I'm thinking when I was, we were talking about this, it's interesting, I got my kids talking about it at the dinner table last night. It's quite interesting, and they usually go, oh, that's the sort of boring stuff my mum and dad talk about. I think the experience of GPs at the deep end in Scotland has been that people in power do listen to GPs. They listen to the college at times. They listen to groups of GPs, and they do listen to the stories that we have to tell. You know, we are privileged in our jobs, and that we get on a day-to-day basis to hear the stories of people's lives and the impact that government policy, social policy has on people's lives day to day. And we had some really quite remarkable I suppose people listen to us as when the GPs at the Deep End Scotland, because we did a report several years ago now about the impact of welfare reform on patients, and feeding directly into the sort of really strong, important role that the social determinants of health plays. And it did get listened to, and it has had some traction. So I would say to people, sometimes as GPs we can feel like we're a tiny wee piece in a massive puzzle, but actually our voices have power and they're important. So that advocacy role is really important. Thinking about it from a practice level, we also did some work in Scotland looking at the role that welfare advice embedded in practices can have, and the evaluation of that small pilot work was overwhelmingly positive in Scotland. And as every time this work's been done, it's been evaluated as a positive contribution. So that in itself might be something useful that practices can do to think about how they might mitigate the harmful effects of welfare policy.
Sure. Thank you, Andrea. Donna, did you want to come in, and then James?
Thank you. Yes, just as just as you were talking there, I would just firstly to say that I would love it if we had an inclusion health lead in every CCG. It's something that I've been talking about for a long time. It's yet to materialise, but I think now more than ever, as we're sort of in this slightly strange transitional period where we haven't really yet seen the full socioeconomic impacts of COVID-19. So it feels like perhaps looking a little bit over a cliff edge, or maybe standing at the bottom of a cliff and waiting for something enormous to happen. We came into COVID-19 really on the back of a decade of austerity, and the impact of that was profound in terms of hunger, in terms of being a state of hunger, of poverty, of destitution. But again, one of the things that I've seen is that there is power in numbers in a way, because having collaborated not just with other Royal Colleges but also with voluntary sector partners for major campaigns on things like NHS charging regulations, which clearly cause harm to vulnerable migrants, on the duty to refer and the Homelessness Reduction Act, and embedding that and making sure that it's a policy that allows us to recognise and identify and promote inclusion, and promote the sort of breakdown of barriers between health, housing and social care, working across those sectors, both health, housing, voluntary sector, social care, and having campaigns that promote a single message of what we think is essential can work very well. And I've seen it work on a number of occasions. And whether there are more campaigns that we can do collaboratively with our colleagues from nursing and midwifery and across other specialties and sectors, I think could be very, very powerful to add weight to the voice and weight to the argument.
Thank you, Zana. Just thinking about a couple of wee practical things as well in terms of that sort of advocacy role. We invited MSPs and the Cabinet Secretary to come and sit in the practice for a while and just speak to some of the staff, and she spoke to some of the patients as well. And I think that actually changed the way that people perceive general practice. It just, I think, we assume that people know what our job involves and what we're dealing with on a day-to-day basis, but I don't think that's always the case. And I think sometimes as well, when you can involve your patients in lobbying for services that you're worried are going to close, for example, by creating a template letter that can go to the local MSP that you have several copies of in the waiting room that patients can sign if they so desire, and we can post them, or having a petition that folk can sign. So it's just about enablement, I think, as well, and just sharing ideas around what lobbying and advocacy can look like, because often they kind of go hand in hand. James.
So to follow up on some of those points, I think it's utterly outrageous, isn't it, that children are going hungry on a seasonal basis every year, and no children should be going hungry anywhere in the world, but here in a country that has the money and the funds and the resources to stop it happening is particularly outrageous. I think it's crazy that it takes footballer to cause a U-turn in government policy. I'm enormously grateful to Marcus Rashford for doing it and for the effect of his work. So brilliant congratulations to him and to everyone who will benefit from that. I would love to see the college sort of campaigning as we do on many fronts around poverty. If I were to pick one thing at the moment that I think would really help in that regard, I think it'd be campaigning for universal basic income, because poverty in places like this is actually a solvable problem, and that is one way of solving it. I know in Scotland there's serious discussions going on about that at the moment, and the same would be equally applicable here. Again, looking at sort of practice level interventions, we can help. And Andrea gave a really good example of the deep end embedding financial advisors into practices and the results that it came up with. And if I remember rightly, it identified something in the region of 150 grand's worth of debt and then took action to mitigate for its effects. And also through income maximization, so actually just getting people access to the benefits they were entitled to, managed to increase people's income in those practices by £850,000. And we know that poverty drives ill health, so that makes a real difference. Of course, in order to know people are living in poverty, we have to ask and we have to get involved in that kind of stuff. And our housing, we're actually helping a group at the University of Cambridge looking at whether screening for poverty and other social determinants of health at registration in general practice is useful, but also acceptable to the people who have to go through it. So I think the college is really immersed in this kind of stuff, and I think we will continue to strive until we get results.
Good to hear. Thank you, James. There's been quite a lot of stuff coming in on Twitter from a lot of different people, actually. So I'm wondering whether I'll maybe sort of move to this area next, and then we'll maybe go to a recorded question that's come in, which is a very important issue to address as well. But I guess one of the things that we've all seen and has been phenomenal in the pace of change in the last 2 to 3 months is the change from being a largely face-to-face specialty to one that's delivering the majority of its healthcare digitally. And of course, while there are lots of opportunities with this in terms of keeping things safe and improving access for some people, flexibility around working and people who both colleagues and patients, and avoiding unnecessary travel, there are obviously potential downsides too to the people that we're not seeing face to face or who aren't able to use digital healthcare. So there's the potential that it may worsen health inequalities. And I just wondered what our panelists have been aware of in terms of potential worsening of health inequalities with our new digital ways of consulting, and how we might mitigate against that, given that digital healthcare is going to be with us for the foreseeable future. Is there anybody that would like to? We'll take Becks first, if that's okay.
Yeah, I wish I had solutions. I guess at the moment I feel I can contribute mostly worries, which I'm sorry isn't terribly helpful, but I guess I think they're things that we should be thinking about. I am really worried about intimate partner violence. I'm really worried that we're not picking up, but it's very difficult, I think, to know who is in the room with our patients, who has control over access to remote consulting options. That extends to English as a second language. And again, inequity is intersectional, so there will be people at greater and greater risk from this. And I'm worried about how we really reach those populations in this context. I think there are, and people will be aware of concerns around child protection, around people who don't have access to the type of devices we're reliant on now. And I know I have a lot of patients we're using. How wonderful that we can use Accurix for video consulting and for people to send me photographs of their rashes, but lots of my older patients don't have mobiles, so that knocks that out straight away. And lots of my other patients don't have data or Wi-Fi. And so I think we're probably all grappling with similar problems, actually, around how does that change our attitude to risk in face-to-face consulting. It's really difficult in the absence of, I would argue, good local population prevalence data on COVID to know where we should be balancing that risk profile. I think inevitably we need to be much more proactive than we probably had been before. But again, that places more demands on workload. And I'm very conscious that as we move through this, we're going to be coexisting with COVID. There isn't going to be a post-COVID anytime soon. And so we need to be mindful about how we kind of staff our services for the long haul with this. I'm sorry, that wasn't terribly upbeat, but they're definitely things I'm thinking about at the moment with regard to our own patients.
Yeah, no, thanks, Becks. I think that's really well articulated. Some really, really concerning things that we need to factor in. James, you wanted to come in, and then maybe Andrea.
Yeah, absolutely. I totally share Becks's worries. As a group, we recently wrote a letter to the BJGP raising exactly that issue. We know from research pre-COVID that telephone and video consultation, it favours younger people, it favours people with fewer problems, and what we can infer from that is it disadvantages people who are older, disadvantages people who have complex comorbidities and complex social issues. And it restricts access for all those people who Becks was talking about, all those people who experience digital poverty, people who don't have access to data, to smartphones and the rest of it. Encouragingly, I got an email just today actually from NHS at Home, the people who are looking at kind of improving healthcare at a distance. And they're really enthusiastic about exactly this issue. They have plans there they're looking to discuss and put in place to mitigate the effects and the health inequalities of this, and to really try and target people with the greatest need and the greatest risk of exclusion. So that's great, and that's going to be really encouraging conversations to have. Like we've all been saying today, I think the answer lies in seeking out the people who are going to be disadvantaged, the people who don't see. We've heard it several times today already. Engagement is a two-way thing. People just do not attend for no particular reason. There are reasons behind all of this, and people who are often described as being in hard-to-reach groups generally aren't in hard-to-reach groups. People who are experiencing homelessness on the street are right under our noses every day of the week. It's just a question of having the assertiveness kind of reach out there, and the kind of relentless, unconditional kindness, as one of my colleagues likes to say, to pursue people in a kind of gentle way, but in a way that actually gives them genuine access to healthcare.
Thank you, James. Andrea, did you have a point as well? And then I'd like to move on to the pre-record question, because it will raise some important things that I'd like to be able to cover tonight as well.
Yeah, so I suppose I was going to say something that's slightly unpopular. And that, you know, so missingness in healthcare is not a new phenomenon. It's always been around. And I suppose when you work with inclusion health populations, like I have done for a long time now, you kind of know that intuitively, because you spend a lot of your working week trying to find people, trying to ensure that they get the care that to meet their unmet health needs. And so I did lead on some research looking at patterns of missed appointments in general practice, and we found, and that was a sort of population representative sample of a good chunk of Scotland, and we found that not only is it a worry, it's actually a really quite big risk marker for early mortality. So we've been thinking about this quite a lot as a group, and there's two principles that might help practices within their own unique context think about this. And one of them is to think, you know, with all this new digital innovation, how permeable is my practice for every single person within my practice list? For the person who has no digital literacy, no phone, struggling to find money to heat their house, let alone to have enough money on their phone, how can I make it that they're able to access the care that they need from us? And the second thing is thinking a bit more about stickability, and to me that's one of the themes that underlies quite a lot of the really amazing, impressive response that's happened amongst not just GP practices, but as Zana was talking about, all the various people that are involved in the network of caring for people. There's been quite a remarkable thing happened in the city I work in Glasgow, with lots of different people coming forward and helping out. And that's been a wee bit about sticking to people and about making sure that things follow. So it's our role, I think, as GPs going forward to think about those two things.
Yeah, thank you. So it feels like it's important to make sure that evaluation considers these groups and then thinks about ways to mitigate and how we make sure that people are as tech enabled as they can be. And I wonder whether as well, ultimately we would like to use our new virtual world to free up the time, face-to-face time, for those who need it the most, either medically or socially. Might be a way of kind of thinking about it. I'd like to move to a question from the BAME forum, if that's okay. So I'm going to put myself on mute and
My name is Dr. Nelda Fletcher. I'm a GP working in London. BAME doctors have rallied to the call to help with COVID-19, and a disproportionate number have died in the process. Can the RCGP now assist BAME doctors with the following? 1. Help to implement the recommendations from the Fenton report to enable BAME doctors and the community to survive in the current pandemic. 2. Assist BAME doctors who are disproportionately struck off the medical register by the GMC or given the harshest disciplinary sanctions. And finally, 3, help GP practices which are being discriminated against and disproportionately closed by the CQC. We need your help, please. Thank you.
So thank you for these really important questions, Nelda. And I wondered if it would be useful to firstly just kind of explain some of the college role on this. I hope the panel won't mind me just taking a minute to do that. So Nelda is on our BAME forum, which was set up a year ago at the college so that we could better understand and work on factors both internally as a college and also externally with stakeholder organisations that are exacerbating difficulties for our BAME colleagues and for patients. So we're actively listening to this group and keen to work sort of constructively to support members and appropriately challenging questions like the one that Nelda has just asked for us, help us to determine how we might also direct our influence externally. So I guess the short answer to the question is yes, where we can. As the Scottish Chair, it's probably also important to say that we do have separate reviews and regulatory processes in different parts of the UK. And so some of the challenges that we're facing to combat this do vary across the country, but there are a lot of common themes. And you mentioned the Fenton Review, which is of course within the English Public Health Report, which shows the disproportionate effect that COVID-19 has had on BAME doctors and patients. I know that some of our panel have thoughts on this, which I'm keen to come to, and that COVID isn't the great leveller that some commentators have suggested that it was, but actually it has further exposed existing and deep inequalities in health outcomes and aspects of our healthcare systems that really didn't work well for our most vulnerable patients. I think it's important to say that the college supports the Fenton Review's aims, especially better PPE for healthcare professionals, supporting doctors to speak up about racism, culturally competent risk assessment tools, and crucially, better appreciation for our BAME colleagues through training. And we'll be working on this and lobbying for change. And I know there was a question on the membership forum about this too, and I want to reassure you that we will be campaigning on accountability as well. So we're hopeful that this will start to help to turn the cultural tide that leads to the larger amount of reporting of BAME colleagues to regulatory bodies. And it's our intention to work with the GMC and the CQC to ensure that their procedures are fair to members, as well as encouraging members who've been unfairly targeted to reach out to their union or to us for support. And the health service can't operate and effectively keep patients safe unless the workforce has confidence and trust in its regulators. So it is an important part of how we work. But during COVID-19, it's been interesting to see how it feels with less regulation and less bureaucracy without a deterioration in the standard of patient care. So we're keen that proportionate fair regulation is in place so that we can maintain patient safety and public confidence, whilst not being subjected to unduly burdensome regulatory processes. Now, we've also had a question from Sonali on the forum about why the college hasn't extended words of solidarity and comfort to members. Our chair, Martin Marshall, sent a message out to members through his blog last week, but our public message on this is going to be through action rather than through messages of solidarity, which we didn't feel would be sufficient really in terms of what we want to achieve for our members. And we've been working on our equality, diversity and inclusion action plan for over a year now, and have diversity and inclusion training embedded into the college for both staff and officers. And it's a principle that we'll be embedding 2 more into our lobbying work. And next month, a separate panel event like this is planned for members, which will focus solely on the BAME workforce and patients and the issues that are being raised, which are so important, which means that we can focus tonight's discussion on health inequalities during COVID and dedicate more time to discuss these other important issues more fully and provide an update on the work that the college has been doing to date and is planning to do to address these concerns. I wanted to speak to the panel about this too, what you think maybe some of the policy solutions are in this space, or how we can protect our BAME staff or colleagues who are more likely to be working in areas of need across the UK. For example, when we're hearing about COVID risk assessment tools, might there be pitfalls for vulnerable communities or more deprived areas? So I just would be interested to hear some thoughts from the panel on this issue. Thank you. Is there anyone that would like to speak on this? So I'm going to take Becks first, if that's okay.
Just to come in very briefly, it's a huge area. It's hugely important. I think I would be very wary of separating out BAME issues and structural racism from health inequity. They are kind of one and the same. Just to share, we will be bringing out publicly in due course. It's not public at the moment, but have done some analysis looking at where BAME GP colleagues are predominantly working. And as you would imagine, it correlates very strongly with areas of high deprivation. And I think it would probably be inappropriate for me, while that isn't formally in the public space, to comment too much more on that, but it highlights a really, really important problem here that is the kind of magnification of structural inequity. It is what we would expect, and it is particularly the case in single-handed practice. So there is something really important, I think, about how we protect our patients and how we protect our colleagues and how we work together to do that in a way that, as you say, is culturally sensitive.
Absolutely. Thank you, Becks. Rachel.
Thank you, Kerry. So I completely agree with you, Becks. I think there's a lot of crossover actually within some of the solutions for tackling some. And one of the things that the Fenton review actually talked about was thinking about the content of education. And as a trainee, I suppose I've been thinking about that quite a lot. And actually, I think there's a lot of content in education that can be improved around this. So there's a lot of work to be done in terms of improving research around representing BAME groups, but also vulnerable groups generally, and also some of the learning that we do around sort of pictures in textbooks representing white people, and not actually being completely representative of the patients who we're seeing in our populations. Normal values for blood tests, not necessarily representative. The terminology we're using, things like erythematous, cyanosis, they're all things that actually don't represent the patients who we're seeing. I think there needs to be a clear curriculum, including the specific challenges for BAME groups. Unfortunately, this is a social determinant of health, and this is something that we are sort of talking about today. And this does impact, and we've seen from the data that being a member of a BAME group means that you are much more likely to die from COVID. I think as a trainee, seeing role models is something that I feel is really, really important. And inspiration would be great within RCGP, general GPs generally, and sort of even starting in medical school for educators and supervisors who show diversity and inclusivity from the beginning to pave the way for the future. I think that's really important. But also, as I said previously, spending time in the community working with patients who are from BAME groups is really, really important. And actually, if trainees aren't and medical students aren't coming across this stuff, then they just don't have that experience. And I think that's really, really important.
Thank you, Rachel. Some really, really important points there around training and education, and absolutely agree with you. Andrea, did you have your hand up, or was it? No, was it James? Sorry, James.
Just to follow up and reinforce on what Rachel said, there was a brilliant comment actually on Twitter. I wrote it down yesterday from a doctor in America, and she wrote that, how is it that we require medical students to memorize the Krebs cycle, but don't require that they learn how systemic racism and health inequity drives human disease? And increasingly we are learning that, and the newer medical schools and all medical schools to an increasing degree, I think, are getting this stuff into the curriculum people are learning. Edge Hill Medical School, one of the new ones, really stands out as pushing those kind of areas, and social justice as a key part of medical learning, I think. Where we are in Manchester, we recently have the Greater Manchester Deprivation Focused GP Specialty Training Programme. Some of our trainees I know are listening and watching in online at the moment, and they're going to be leading on a session on institutional racism and our experiences of it, where it comes from, conscious and unconscious bias, and what we do to change it. And that's going on tomorrow. And I think that's really important, because all this stuff, we can criticize other people, but we're as guilty of it ourselves in all kinds of different fashions. And when we talk about COVID response in particular, if we look at this country and our sort of nations around, we have a hugely diverse population that speak a load of different languages, and how much of our COVID information came out in any other language than English. And pretty much none of it until Docs of the World saw fit to translate it, for which, again, we're enormously grateful. So there's huge amounts that we can be doing in the medical profession. One of the things from the Fenton report that really broke my heart was reading the line that said many people from BAME backgrounds don't access the medical care they need because of previous experiences of racism or poor care that they got whilst accessing care in the past. And that's something we can change, and that's something I think at the moment we're really in a great position to change, and we should.
Absolutely, thanks so much, James. That was an area, an issue that was raised, and I would agree that's almost the most heartbreaking bit is the experience that people remember of when they've tried to reach out for help and how they feel they've been received. There was a question from Sonali on the forum about Michael Marmot and how the college will be advocating for BAME patients, and we've talked a little bit about the role of advocacy in general, but I think it's important to say that it is a key part of our current equality, diversity and inclusion action plan that we'll be looking to make sure that the curriculum and training for doctors takes into account the issues that BAME patients face. Because clearly public health campaigns aren't reaching BAME groups, and as we know from our loneliness work at the college and from the Fenton Review, faith groups and communities and other avenues will be a key area in reaching out to BAME patients to help improve their trust, because it's really sad to hear about those kind of stories. Rachel, did I see your hand go up there? Yeah.
Kerry, just while you're mentioning advocacy, I think advocacy is a really important thing from a trainee point of view, because actually it's not something that I really came across in my education at all until maybe a couple of years ago. And I think this is such a key part to being a GP. And I think it's really, really important that we try and get training in advocacy a key part of education within general practice and prior to that as well. I think sometimes it can feel a little bit like this is a choice for GPs, and I know for all of us sitting here on the panel this doesn't feel like a choice because it's such a key part of the job that we do, but actually I know some GPs don't feel like that's their role, and actually taking that forward as medical students, GP trainees going forward, that automatically, and if we're not showing as role models that is our role, then actually taking that forward means that we are creating GPs who aren't doing that as part of their job, and I think it's really important that we do that.
Thanks, Rachel. I see, James, you've got your hand up, and then I'm going to have to round up, sadly, because it's almost 8 o'clock. Could you believe it?
I think Rachel's point kind of brings it nicely back to Amanda's question there. Sort of how can we make a real difference to our patients' lives and affect health inequalities? And Rachel's kind of put her finger on one of the really big things we can do, which is advocacy. And that's advocacy at sort of college level and national level and regional level, but it's also advocacy for our patients as individuals and families. And, we can add a few months someone's life expectancy by tweaking their antihypertensives, or we can add 40 years to it by getting them housed. And that's something that we as GPs can really kind of punch above our weight with. Where we are in Greater Manchester, there's a campaign going on at the moment around homeless families. We've seen huge amounts done. Homeless folk or people experiencing homelessness on the street being housed almost overnight. And that's brilliant, and we need to make sure that continues. But other people haven't had quite that sort of attention, and homeless families have been really missing out. And we know that people are out there, and the COVID lockdown experience has been gruesome for them. We've had families of 5 people with children with no outdoor space in single-bedded accommodation. And a lot of them have been forgotten about. People who go into temporary accommodation lose contact with social services a lot of the time, with safeguarding, with education and with health. And we as GPs can advocate for that. We can make a real difference. And at the moment, we have this short window of change. I believe some people are calling it a compassionate window, but that window is going to close pretty soon. And we have to fight going back to the old normal. We need to create a new normal. And in housing and in so many other areas, we've had a brief gap where things have come to a stop. That means our influence can genuinely affect change. And I think we're in a brilliant position to do that.
Yeah. Thank you so much, James. And Zana, did you have some thoughts as well?
I think I was just really struck by the comment about not feeling a sense of messages of solidarity. So I really just wanted to, as a minority ethnic woman, an immigrant to this country, I just wanted to send a message of solidarity and to say that, you know, there is empathy, there is understanding there of these experiences from within the profession, and we should harness that and capitalize on that and draw on the many things that have been described by James and Rachel, particularly, you know, around the experiences of homeless families. As the only child of a single parent immigrant mother, I can empathise with that situation of living in a bed and breakfast after I came to this country. I can empathise with the issues around training and education, and I absolutely align my own research with what Rachel is saying, that the sooner the better, the earlier you can transform education from primary school right through, is really, really the key here. Certainly one of the key things to both creating a society where the individuals within it are different and better, and then more willing and able and empowered to take on the problems head on in the way that Marcus Rashford has done. You know, we become a generation then of people who are prepared to do that. So a message of solidarity from me to all of you.
Thank you, Zana. I think that's a great note to end on from the panel. So thank you so much. And thank you to everyone who has fed in questions tonight through all the various social media channels and the ones that have been sent in advance. It's been fantastic. And I hope that we've answered some of them. I know that there are still questions that we've not been able to cover, because we could talk about this all night, I'm sure. Open a bottle of wine, we could crack on. But what we will try and do is we'll try and collate all the questions that we've not managed to answer, and we'll share them with the panel, and we will try and get back to you where we can, but also ensure that all the issues that have been raised tonight that are important to you as our members and as working GPs can feed into the ongoing discussions that we're having around how we develop policy for the RCGP, share practical resources of what we can do as individual GPs in our practice, and also how we can campaign effectively to make this better for all the groups that we're talking about. So I just want to thank everyone for coming along. And if you do want to just learn some more or read some more around health inequalities generally, we've now got a dedicated health inequalities section on the COVID Resource Hub on the RCGP homepage. And if you do click on there, you'll find some vlogs that James and I have recorded, and some frequently asked questions about the role of GPs in supporting socially vulnerable groups, which is useful if you're thinking about what kind of templates you might want to use to be making outreach phone calls. And also a recent recorded interview with one of my personal heroes, and I'm sure for many of us, he is our hero, Professor Sir Michael Marmot. And we've got some additional practical resources planned, which we'll be adding onto the site as well. So our next session will be chaired by Gary Howsam, and it will feature all of the devolved nation chairs talking about the future of general practice. So I might see some of you there again. And it would be great for you just to keep feeding in questions as you've been doing. It feels like a really nice way to engage with members, a really important way. You can start submitting questions for that on social media, on YouTube and on the forum, and it will be on the 2nd of July from 7 p.m. same time. So just remains to say thank you again for tuning in. Thank you so much to the panel. It's been fantastic speaking to you all. Take care and stay safe.